Welcome back to another edition of the Hart2Heart Podcast, and my guest today is Dr. Anish Koka. He's a cardiologist working out of Pennsylvania. So, Dr. Koka, welcome to the show.
Thanks for having me.
So, really pumped to talk to you today. I'm not sure if I've had actually a cardiologist on the show before. I've had probably like 30 or 40 doctors. I'm not sure if I've actually had a cardiologist though, so you may be the first one. So we'll probably ask you a couple cardio questions, but before we get into it, just give the audience a little bit of a brief background about yourself.
Yeah, I mean, I like I said, I'm a cardiologist practicing in private practice in Philadelphia, Pennsylvania. I went to I've been pretty much local. I grew up in Pittsburgh, and which is in the kind of the western part of Pennsylvania. Moved to the central part of Pennsylvania to go to undergraduate school at Penn State, and then I kept moving eastward to Philadelphia, where I went to medical school, Temple, and then went to one of the local academic institutions, Thomas Jefferson, for cardiology. And then I opened up a private practice shortly after. So, and I've been practicing in Philadelphia ever since.
Awesome. Cool. So, been to Pittsburgh once for a bachelor party for a couple of days. Pretty cool city. I've never been to Philly before, but kind of want to go there just so I can run up the steps, So I got to ask you, have you been up the steps?
Oh, absolutely. Many times. We've taken many folks there to it's beautiful. It took me a while Philadelphia takes a while to grow on you when you're coming from Pittsburgh. Pittsburgh is like a very much of a Midwest small town. People are very friendly. Philadelphia is gritty. It's got a lot of character. But yeah, it's a lovely city. Really learned to love the city over the last decade or so.
Right on. Well, as a Canadian, a lot of hockey fans certainly love Pittsburgh. Sidney Crosby, he's actually a Canadian from Nova Scotia. So, a lot of people in Canada are big fans of him.
I was actually, when I moved to Pittsburgh, I was born in New Delhi, India. When I moved to Pittsburgh in the late 80s, that was the heyday of Mario Lemieux, Jaromir Jagr. So, man, I was a massive fan at the time. I was a young kid, and I just happened to be in a town where maybe the greatest ever, if you're a Pittsburgher, greatest ever hockey player played. So it's really fun times.
You guys got a good Mount Rushmore. Your top four is unbelievable there.
Yeah.
But anyways, yeah, there's a bunch of stuff I wanted to chat with about today. We kind of connected, I think, on Twitter a little bit, probably over COVID. It seemed like we probably had some like similar views and that kind of thing. And then recently too, I just saw, you've had these conversations with some other doctors about physicians unions, which is very interesting as well. Physician unions. I don't know if I said that properly the first time. So yeah, a couple things that I wanted to chat with you about, but maybe we'll just start off with, a lot of people are going to want to know, about the vax and that kind of thing. We won't get, too hard into, don't answer anything that you don't want to, of course, I got to be careful myself too. So, but yeah, so, when the vax came out, we knew that, there was a certain rise in myocarditis. It seemed like in the 19 to 39 or maybe 16 to 39-year-old population, maybe more, under 30, maybe 16 to 29, probably where the bulk of it was. But there seemed to be some issue there. Do you feel like right now you're seeing any after effects of the vaccine, either in younger patients, older patients at all? Are there any, extra or new cardiac complications that you're seeing?
I really haven't seen anything, longer term when it comes to the vaccine. That doesn't mean, they're not happening. But of course, I'm just one guy practicing. I'm busy, so I do see a lot of people, as you are too. I understand, but yeah, as a one man busy cardiologist show, and generally speaking to other, of course, cardiologists in the community, certainly not seeing a large burden of long-term cardiac issues happening. So it's a little bit different than I think. Yeah, right. So, and also it's also hard, meaning it's very hard. I think attribution gets very, very hard the longer you get from that initial thing, right? Like, obviously, the problem is cardiac disease is just very, very common. Even before COVID,
Very complicated.
cardiac disease was very, very common. In men in our age group, it's the number one killer, right? So if something bad happens from a cardiac standpoint and it's 2-3 years out, incredibly hard to figure out attribution to get it back to some intervention that you got 3 or 4 years ago. So it's a lot easier to do the attribution early on, and certainly early on, as you're suggesting, it became obvious reasonably quickly, even to one busy guy, that there certainly was an uptick in cases of vaccine related cardiac cardiac kind of adverse events happening. But yeah, the long term, I'm not quite aware of it.
That's excellent. I mean, that's good news, overall, that like in the long term, it doesn't seem, again, like so hard to tease out data on that. But, it's fantastic to hear that, in the long term right now, it doesn't seem like there's any increased risks, cardiac wise. It seems like most of the risks were associated basically within the first month or so. Is that correct?
Yeah, it seems like, it certainly seems like that, in the first, and again, I think the main issue, at least from a cardiac standpoint, seems to be, myocarditis, is that inflammation of that heart muscle. And that can, of course, cause a panoply of different things. In the most severe cases, and again, these are case reportable, it's been in the New England Journal and other places, where folks end up, either dying because of severe heart failure, or folks end up needing a heart transplant, end up needing, massive support. And those are these case reports that have been reported. Those seem to be exceedingly rare. And then there's the most common thing that seemed to be happening is, chest pain and the kind of and then that with the, that happens with that acute event when you're having actually injury to the heart muscle. And then beyond that is a bunch of arrhythmias, high heart rates, some SVTs, maybe even some atrial fibrillation. And again, those all, at least in my hands, my experience, seem to be relatively, self-limited. There are, and again, everyone knows in the cardiology community of course, cases where, you've had for patients who had myocarditis, who then have continued to have persistent problems with that. So it's not to say, when I was talking about the long-term stuff, that the folks that do have kind of a bad case of myocarditis, that they don't continue to have kind of persistent symptoms longer term. But in terms of like, you get a vaccine, everything seems fine. And then 3 years later, something is happening. Number one, it's very hard to figure out whether that is related to the vaccine. It doesn't seem to be like there's this tsunami of cases now, from a cardiac standpoint, because, a bunch of people got the vaccine, whatever now, 2021 or whatnot. We were looking for it with COVID, right? Because there's all this concern because the SARS-CoV-2 virus acts on the ACE receptor, and the ACE receptor is, of course, really highly expressed on the cardiac muscle, as one of many organs that it's highly expressed on. And so there was this concern that there would be this tsunami of cases. And early on, there seemed to be some kind of strange injury cases in the setting of acute SARS-CoV-2. But overall, it really seemed like, SARS-CoV-2 did not cause that many cardiac issues. Certainly, there's multiple papers now about how cath labs were actually less busy, after COVID. Of course, that had something to do with people not seeking care because they were scared of going to the hospital. So again, so hard to tease out all these different things. But that being said, there wasn't a tsunami of folks that were coming to cardiologists or to heart failure doctors with, "Oh my God, I had SARS-CoV-2 and now, heart's not working at all." And that same seemingly benign course seems to have happened in large part with the vaccine. Not to say that there aren't, of course, those cases. Again, the incidence, that we were looking at in, I think 15 to 17-year-olds was the highest. Some people estimated around 1 in 5,000 in terms of cases of myocarditis in that high risk group. Yeah, young men, 15 to 17 years old. So in those 1 in 5,000 who have this thing happen, they of course very, very small percentage of them have some severe bad outcome. The large majority of those seem to have a self-limited, course, and then get back to their baseline, uh, you know, uh, not long after. There's an open question about how many of those have little tiny pieces of injury and how important that is long term. But I think that's your question, and I'm not seeing some tsunami of patients having these massive numbers. There's not massive numbers of 15 to 17-year-olds or 17 to 39-year-olds having all these arrhythmias that I'm suddenly overwhelmed in clinic with. So
Okay. Well, I mean, again, that's very reassuring to hear. It seems that, like, if you were going to get injured by it, like severely, it likely would have been in the beginning. And again, not saying that if you weren't, injured, severely in the beginning, that there may not be something, long term. But right now, it seems like if you were, got the vaccine and you're worried about your heart, if it's been a while, if it's been literally after a month, and for 99% of people it's been years, then likely your outcome is probably going to be okay. Which is, again, very, very reassuring to hear from like an open-minded cardiologist like yourself, who I think would say if there was an issue. You know what I mean?
Right, absolutely.
But yeah, so I did want to maybe ask you too, just about some general basic cardiology questions, and really a lot about blood work and tests, because people are really into different blood work right now. A lot of people have sort of not necessarily questioned. I guess some people are questioning HDL. I still think LDL. I still think LDL and ApoB are great markers, but people are kind of looking at these other markers now. So maybe I'll just start there. So I know that the triglyceride to HDL ratio has come up a lot over and over, especially in, like, I guess the low carb or carnivore community, or some of these other, communities that are thinking that, LDL and ApoB is not, a significant risk factor for cardiovascular disease, which again, I disagree with right now. But so what do you think overall of the triglyceride to HDL ratio? Like, is this something that people should be putting a lot of weight into, or is this something that you don't utilize that much in your practice?
I mean, I think most cardiologists probably don't necessarily utilize the ratio itself, but indirectly, I think we're all utilizing it, because I think to the most cardiologists, a high triglyceride is not good, and
Yeah.
and that's what the triglyceride HDL ratio is kind of getting at. Oh, sorry, and to most cardiologists, of course, a low HDL is not good, right? So the higher your triglyceride, right, and the lower your HDL, the higher your triglyceride to HDL ratio will be, which is, of course, indicative of then higher risk of having cardiovascular events. But that's, when we're looking at the numbers individually, and we see a high triglyceride over, say, 150, and this is where I think the ratio may not it may not be as descriptive as looking at the individual components themselves, right? So if you have, so if your triglycerides, I think, to me, it's more meaningful to know what the actual numbers are than to actually do the ratio. So if your HDL is low, if it's less than 40, yeah, I mean, that puts you in a higher risk category. If your triglycerides then on top of that are over, certainly over 150 is considered abnormal. Again, depending on, I guess, what lab range you have, but generally speaking. And then once you get over 250, once you get over 300, that's definitely very high risk. Now, if your HDL is normal, or say your HDL, this is the issue, if your HDL is 80, right? What is the incremental prognostic benefit of having an HDL of 80 versus having an HDL of, say, 38, right? Like all things, there's this law of diminishing return. So I don't quite believe that there's this linear good outcome that's happening if your HDL is 80 versus if your HDL is 38. Meaning, yes, it's much better for your HDL to be 48 than to be 38. Yes, it's better for it to be 58 than 48. But as you get higher and higher, you have this diminishing returns on how good it is. So that's where that triglyceride HDL ratio will kind of throw you off. So if you're one of these people that walk around with super high HDLs, hey, great and bully for you, but that doesn't mean you should ignore your triglyceride of 300, right? And this is where I think I get a little nervous in terms of some diet that boosts your triglycerides a large amount. Hey, but your HDL is 50, 55, but you compute the ratio, and the ratio says, hey, look, I'm not that bad, so I'm going to be okay. I'm still, I'm still a little nervous about what exactly that high triglyceride is going to mean to you in terms of how likely it is over time you are to lay down plaque. And then, of course, on top of that, the question is, well, why are we? If you like the triglyceride to HDL ratio, why? That's again driven by these triglycerides, which is this sticky lipid molecule that is floating around your blood vessels. Why are you not also? Why is the LDL story, which is also a sticky molecule floating around, why is that not also somewhat convincing to you?
Yeah, I agree with that. And one question I have about that. So there are, people out there like now, like Dr. Peter Attia. I mean, I think he might be on Repatha, bempedoic acid, Easytrol, and like something else. So like, it seems like he just wants to get his LDL as low as possible. So would you say that would be like, why isn't he trying to get his triglycerides as low as possible? And like, would that have like a similar effect? And meaning like, I know that, the LDL may be a better marker, but in terms of trying to get it as low as possible, like, is that ultimately the goal for triglycerides as well? And again, I know we're seeing law of like diminishing returns. Like, okay, once you get your triglycerides so low, maybe it doesn't have to go bottom out. But like essentially, if you want to optimize. And again, I'm not really someone who advertises for that too much, because I think then your life just becomes too, tricky to some degree. But like, would you want your triglycerides to be, as close to zero as possible, essentially?
Again, I think there's there's all this issues related to how you get there, right? And like the problem is to drive your triglycerides that low, or even drive your LDL to be like in the 20s. It's going to require a significant amount of effort. You see, Dr. Attia is on, 3 or 4 different meds. And now it's like, well, again, there's a lot of diminishing returns in terms of like, what is the difference of having an LDL of 20 versus 40? Like, are you like, what is that clinical benefit? How large of a trial would you have to do to show that? And so the same thing applies with the triglycerides. So I think I just don't, I'm a big fan of the law of diminishing returns. So I just don't know, what is the big impetus to go from, low to very low. And I think we've established this with LDL. LDL, it has primacy because it was kind of one of the first molecules that was able to prognosticate risk, right? There were these beautiful studies done, in these Lebanese villages, in these folks that had hereditary familial hypercholesterolemia, and we were able to elucidate what their total cholesterol is, what their LDL is, and you were able to make these beautiful family trees of people that had so much cholesterol, had their LDLs were so high that it was leaking out of their skin, right? They had these xanthelasmas, and they had stuff that was coming out on their eyebrows. And anyway, so these folks, right, who had LDLs of like 600, 700, 800, you had these beautiful family trees. They were tragic family trees that were made about these folks that had this high cholesterol, this like fatty tissue that was able to be seen in their blood vessels eventually, and again, and then they also had these skin manifestations, right? These cutaneous manifestations, and like so many, all of these folks were having heart attacks at the ages of 18, 20, 22, 23. So, but again, those numbers, right? Those LDL numbers were like 700, 800. There were these wildly crazy
It's
numbers. We're
wild.
talking
Yeah.
about LDLs of like, 190, bringing them down to 130, right? So even somebody with an LDL of 190, right? If you look actually at those old old those old case reports and stuff, these were wildly elevated LDL numbers. They did not have statins. They didn't have any way of really lowering their LDL artificially. No pharmacotherapy to do it. And you would see these, obviously these crazy clinical markers where they were having heart attacks at the age of ridiculously young ages. So that's why LDL has such primacy. Now, and again, I guess it should have been predicted that, as we became a safer and safer society, and now most people's LDLs were 180, 190, we've had this steady drift down in terms of where we want you to be. I'll point out that the LDL guidelines, in terms of where you want them to be, where it's okay to be, they have really dropped down in concert with introduction of new agents to reduce your cholesterol, right? So it was no accident that the LDL guidelines, in terms of where you wanted to treat to, were changed, in part and influenced by the fact that PCSK9 inhibitors, the injectables to lower LDL, they came out, right? They came out, and they need a market to and statins are so good at reducing your LDLs, most people's LDLs to 100, right? The only trials they could really run was say, okay, you have an average LDL of 110 and you're high risk, and on top of the statin, we're going to give you a PCSK9 inhibitor and see what happens. And when you dropped that LDL from whatever, average of 105 or average of 90 to 70, yes, you see clinical benefit, but the benefit is much smaller than the benefit you see going from 190 to 100, right? So that's the
Yeah.
benefit of this is the benefit. So we know that, and somebody would have to show me something very strong to suggest that whatever LDL marker you're improving, whether it's going from HDL of 40 to 50, or whether you're going from a triglyceride of 100 to 50, that same law doesn't apply. We've done that experiment. We've done it with LDL, and it's shown that the benefit is marginal. So I think what Dr. Addy doing, maybe it's beneficial, but I'm fairly certain that it's a very marginal improvement, and you probably want to spend your life in other pursuits that are perhaps more productive than getting your LDL from 40 to 20 or something.
Yeah, no, I completely agree with that. And I guess coming back to my question too on the triglycerides and why I sort of asked it is because I've heard and I taught, and Lane Norton's talked about it before on Andrew Huberman, and I've seen a couple myself. I should look into them more, but these Mendelian randomization trials with LDL, and essentially that's why they're saying that to get it as low as possible, because if you look at the trials, it just you can almost draw almost a straight line between LDL exposure and cardiovascular risk or mortality to some degree. And so I wasn't sure if you could draw a similar-esque line with triglycerides, because I never heard him say I'm going to pound the phenylfibrate and get that down and get my triglycerides down to zero, or whatever it is. But if and I don't know if they've done this, but if they were to do some kind of trial like they've done with LDL on triglycerides, do you think it would basically be the same? You could draw a straight line, the higher exposure to triglycerides, your higher your risk for cardiovascular disease. Again, I know HDL is going to play a role in that too, so it's kind of hard to answer, but do your best, I guess.
Yeah, no, I don't. I think it's. Again, the whole straight line, I think it's probably more it's not going to be a straight line, because it's going to be the law of diminishing returns. But I see what you're saying in terms of time exposure. Yes, yeah, no, I think, I'm sure triglycerides would show a very, very similar thing. The patients that have really high triglycerides. But this is what I mean in terms of the debate, what the debate is, right? There's no question having a triglyceride of 300 is super high, and that you don't, if you leave your triglyceride at 300 for 30, 40 years, you're going to have a significant problem. Now, what about if you have a triglyceride of 140 versus having a triglyceride of 40? That's the experiment that one needs to see. And I don't know that you're going to be able to show some massive linear benefit going from there to there, going from triglyceride of 150 to say 40, because of what we've seen with the LDL stuff. So all these Mendelian randomization studies, they're all okay. I get it, but they're all trying to simulate an RCT, and in this space where there's so many different variables, you can't lean very heavily on mechanistic reasoning. There are places where I'm a big fan of mechanistic reasoning and using real world studies to kind of buttress mechanistic reasoning to arrive at what we think is epistemic truth. But wow, when you're talking about cholesterol and lowering it, and there's so many different variables, you have to show me an RCT that suggests that you're gonna have that benefit. Without that, I think what we've learned with LDL probably holds throughout.
Okay. That's a very good answer to that question. But speaking of actually mechanistic studies or kind of mechanistic thinking, and so I have a little bit of a theory or something that I'm kind of betting on here a little bit for cardiovascular health. You let me know if I'm off or what you think. So I've seen some studies come up that shows that CRP seems to be, a fairly good independent risk factor for cardiovascular disease. So that's sort of one sort of statement that I'm making. So, if that's not true, then my second half wouldn't be true. And so to my knowledge right now, there's no pharmaceutical drugs out there that lower CRP. I mean, I know there are, like valsartan, for example, lowers CRP, and there's, tons of other ones, tons of other ARBs, angiotensin receptor blockers for people who are listening, a very, very common class of medicines for lowering high blood pressure. And some of them have a very nice side effect of lowering CRP or C-reactive protein. So inflammation, again, should have said that at the beginning. So there's a couple of things that I've seen that can lower CRP, and one of them is boron. And so I've never seen, if you go on PubMed, you won't find anything on boron for cardiovascular disease, or if you do, it's very, very minimal there. But I'm sort of thinking, again, just sort of hypothesizing that, if CRP is this, big bad, independent cardiovascular risk factor, which, some of the studies sort of indicate that it is, then potentially using something that could lower CRP in theory should help, lower your risk of cardiovascular disease. So, I'm kind of, betting on boron to be something that people may be able to benefit from.
Yeah, I mean, I think the one thing that has been looked at from so Paul Ridker was the I think he was the Brigham, one of the Harvard schools, and his was the theory of the inflammatory hypothesis, and that's why CRP is an inflammatory marker, and so he showed that patients with relatively low LDLs with high CRP levels continue to have were much higher risk than people with low LDLs and low CRP, right? So that, in some way, that's the mechanistic basis to prove, hey, there is a CRP story, there is an inflammatory story to this, and should we be looking? So that, of course, the translation of that, because as you're saying, you don't have any great data, massive data on what anti-inflammatory to use. And by the way, again, when you're in these molecules and how you're affecting a complex disease like coronary disease, without RCT, it's so hard to figure out because there's so many moving parts, right? And of course, we have evidence to suggest that there have been anti-inflammatories, Vioxx, right, taken off the market because of higher cardiovascular events, right? Even the HDL story, just again, just to send the message home to some of our colleagues and some of the nutritionalist folks in the space about how easy mechanisms seem. There's a few $billion, many $1 billion spent on a drug to artificially raise HDL, right? And that drug increased mortality. There are no more. The pharma will not do any more studies to artificially raise HDL. Okay, so that beautiful mechanistic hypothesis with the Apo Milano, folks that had the very high HDL levels that had almost no coronary disease, right? Everyone went after that to say, hey, if we raise people's HDL level, we are going to massively reduce cardiovascular disease. It's going to make LDL seem like nothing. I mean, statins are dead, right? That was the thinking. And that's what billions of dollars went into raising HDL with a drug called tirzepatide, right? You don't know about the drug because it was never approved, because they pulled and stopped the trial early because there was higher mortality seen in the tirzepatide arm. All right. So mechanistic reasoning is like, it can only take you so far, I think. Anyway, sorry for that little tangent. So, but
no, I think it's really important. But just one point before you go ahead, there is that if you're going to do any mechanistic, thinking, especially if you're going to implement it into your life, like make sure it's completely benign. Like I'm okay
Right.
to bet on boron because
Correct.
if you take boron and it doesn't work for lowering your CRP or lowering your cardiovascular disease, there's no risk. I mean, maybe your bones will actually get stronger to some degree, but so, I'm okay with sort of betting on things like that, but I'm not okay with betting on things that would have high risk. But I didn't mean to cut you off there, Anish. Go ahead.
No, that's a really smart approach, and then that allows people to stay open and not be rigid when it comes to EBM. Otherwise, in the EBM straitjacket, like what can you do? There's a very limited number of things you can do. So you really, yeah. So that's a nice frame. That's a nice smart frame to think about. It's like, all right, go ahead and try things. If you think NAD seems like a molecule that is relatively inert, benign. We have lots of it in our system. People want to try NAD, go ahead. We don't have fantastic, great data on it, but you could be open to it. On the other hand, rapamycin. Anyway, that's another debate. But in terms of the anti-inflammation hypothesis, right? There has been a drug that has been trialed in patients with coronary disease that is a very strong anti-inflammatory drug. It has very strong anti-inflammatory effects, and that's colchicine, right? Colchicine is a very powerful anti-inflammatory drug. Colchicine is used in one of the most inflammatory conditions that we as cardiologists treat, pericarditis. Pericarditis is acute inflammation. I mean, it's just severe, you've probably run across some patients, but severe chest pain when you have a severe bad case, right? It's just that lining of the heart is completely inflamed and patients are just miserable and in pain. And guess what we use for that? We use the two inflammatory, we use NSAIDs, ibuprofen or indomethacin, and then we use colchicine, right? And colchicine is a powerful anti-inflammatory. And as for that reason, they ran a trial looking at colchicine in patients with coronary artery disease, right? And what I'll point out for the inflammatory, for the folks that are super excited about the anti-inflammatory effects, is that the effect size is small. It's not huge. Now, maybe you shouldn't expect huge effect sizes in any primary prevention CAD thing, right? But we're kind of so spoilt with statins in high risk folks that I guess that becomes kind of the baseline kind of marker. But just to give you a sense, there was a study done. The study done. It's published in the New England Journal of Medicine. Colchicine versus placebo, about 2,700 patients in both arms, and there were fewer cardiovascular bad events in the folks treated with colchicine, right? The difference was 2.5 per 100 events in the colchicine arm versus 3.6 in 2,700 per 100 in that arm. So that was statistically significant. But if you look down and look at and you break down, okay, are you at any less chance of dying? All right. Because in the folks that were taking colchicine, no, they were basically exactly the same. What about ischemic stroke? No, just almost exactly the same. If you look at MI, right? MI rates were 1.1 in the myocardial infarction arm and 1.5 in the placebo arm. Cardiovascular death, absolutely no change, right? So in terms of how much bang you're going to get, even in patients that were relatively high risk, people that had known coronary disease, okay, I think that's exactly the frame to take it. I think colchicine, if you want to take it, yes, there has some potential benefit. I think the benefit is going to be, relatively small. But I think that would add to the boron hypothesis, especially if boron has a robust effect on CRPs, especially in your patients that say are at an LDL goal. Say you have somebody who has coronary disease, they've got a 60% coronary lesion, or say they've had a stent in the past, right? And their LDL is 60, okay, on some low dose statin, but their CRP is remaining elevated at like 4 or 5 or something, or 6 or something like that, right? So you may want to consider colchicine is what has the hard EBM evidence behind it. So you may want to consider colchicine, but if for whatever reason you can't get it, or if you think boron may be better than that, yeah, I mean, it's I think it's a worthwhile conversation. I'm not I'm not actually. I'll have to look up. I'm not. I don't actually know that much about boron and how much it does reduce CRP, but so I'll have to look it up and see.
Would you or have you prescribed colchicine to any of your patients? And if it did, I imagine it would be to someone who has, a low LDL, but then a high CRP, and you're the perfect patient for it.
Yeah, absolutely. Yeah, I have in patients that, I've had a patient who had a very high calcium score, yeah, I prescribed, we gave colchicine to, and again, it's a conversation. I think when the event rate differences are so small, right? It's really it's a patient sensitive preference. And a lot of times it's the patients that are bringing up, hey, is there anything else I can possibly do, to reduce my risk anymore? And I think colchicine is a reasonable option, certainly given what the evidence says. Yeah.
Very interesting. Okay. You taught me something there. Really appreciate that. Want to move on to another kind of newer, I guess, cardiovascular marker that a lot of people are ordering these days. I certainly didn't order it until a few years ago. So Lp(a). Is this something that people should be worried about? And do you recommend, people getting this test done? Is it as impactful on, cardiovascular disease as some people are making it out to be?
One of the things with all these markers, whether ApoB or lipoprotein (a) is that, you have to understand, I think that the public really needs to understand that the issue that the influencer, the nutritional / influencer, health influencer community has is that they need to be selling you something different than what your doctor is telling you, right? So some of the things I think is driven by the fact that if they say everything that your doctor is saying, it's like, well, there's no differentiator.
Yeah.
And so I think people should have, I listened, I think Peter Attia is a very smart guy, Andrew Huberman are super smart guys, and actually listen to them because, obviously I'm interested in folks that are kind of thinking differently about things. But I do get the sense that there's this there's a little bit of pressure on them in some senses to be coming up with something that's new and something that other people, that the regular doctor is not telling you about, just to kind of get that sense that there's some secret that's there. But no, Lp(a) has been known about. It's another sticky molecule that's been known about for some time, and it has been shown that people with high Lp(a) levels are at higher cardiovascular risk. The problem again comes in, okay, please do the trial to show that if you have that targeted at people with high Lp(a) levels, like what can you use to reduce it, and is there benefit? Is there a clinical benefit that you're going to show with that? I think so. The way I use it is in patients that I think have high residual risk. You can define them as folks that are for instance, South Asians have a lot of times have these high Lp(a) levels, right? So these folks have an LDL of 90, and they're on like 10 of I don't know, simvastatin or something like that, and their Lp(a) is sky high, right? That's a group of folks, and they have a family history of premature coronary disease. All right. Now the question that frequently comes up there is, what else can I do? So this is where I'm using these additional markers, right? In somebody that doesn't have these additional risk factors, and their LDL is sitting at 60 or 70 or something like that, I'm not entirely clear that we have a good significant base to say that getting that LDL from 60 to 40 is going to do anything. The issue with Lp(a) is that Lp(a), the only thing that really reduces it is niacin. PCSK9 inhibitors also can reduce Lp(a) as well.
I'm glad you said niacin though, just because I heard Dr. Peter Attia say, it's only PCSK9 inhibitors. And so I have a small relationship with Andrew Huberman where I can email him. So I emailed him and I said, listen, there's a meta-analysis on niacin. I think it was 6 RCTs that said that it lowers it by 30%. And I don't know, he didn't get back to me yet, but anyways, I did see that. And then again, okay, I don't want to go off too much on a tangent, but niacin is very interesting because like it basically, if you were just looking at blood work, it's insane in terms of, lowers triglycerides, lowers LDL, increases HDL, like it does everything you want. But then if you look at the trials, it doesn't have any kind of effect. So it doesn't produce any decreased mortality. And then there was something that came out this year, maybe a few months ago, or maybe it was in March or April, something like that, I think, where it said that they identified a niacin metabolite that could be, potentially, linked to cardiovascular disease. So it kind of makes sense because it's like, if it's doing all these supposedly amazing things, it's got to be doing something terrible if it kind of comes out like even overall, you know what I mean?
Right, and that gets to this yeah, again, it goes back to this whole mechanistic reasoning in this place. I think mechanistic reasoning fails over and over and over again here, right? Niacin, I mean, amazing, right? And niacin is like basically a B complex type of vitamin, right? B6 or something like that. And it significantly, 30 to 40% reduction in LP little a. It reduces it gets your triglyceride levels much better. It also raises your HDL a significant amount, right? And despite that, you are seeing that, in the AIM High trial, there was absolutely no difference seen in clinical events, right? So it obviously makes you nervous that niacin could be doing, yeah, exactly what you're saying. So this is the issue with, checking LP little a. Like, I think it's okay to check LP little a if you're going to use it to try to get to a lower LDL target, okay? Because that law of diminishing returns I keep talking about, maybe in your people, and again, this is speculative, maybe in your people who have an LDL of 80, who also have a high LP little a, maybe in those folks, that benefit of reducing your LDL from 80 to 50 is going to be much, much higher than the average person who has a normal LP little a or has a CRP that's normal. So I think most conventional cardiologists are using the LP little a and CRP to be more aggressive with statin therapy to get your LDL to be lower, because we don't think we necessarily should run around lowering everyone's LDL to 40 or 50, but in people that have these other high risk markers, we know they're high risk. And the problem is, we know that statins, PCSK9 inhibitors are the ones that really lower your cardiovascular event risk. Then we should use these markers to decide on lowering statin therapy. The influencer community, the podcasting community, obviously very much loves biohacking and wants to make those numbers look amazing, which is fine if it makes you feel good and whatnot. But I don't know. Certainly the clinical trial data is not exactly supportive of that. Again, clinical trials, of course, are limited, and it's patient selection, and of course, Adia and these guys will and all of us, you, me, can rip into any RCT and be like, all right, this is why ivermectin never dies, and this is why niacin will never die, and whatnot, because of course no trial was ever going to be perfect. But go ahead, do the trial. Dr. Adia must have enough money to, at this point, run an institute himself.
And again, for the bros out there, compare it, say, to something like protein. So it's kind of common that 1 gram a pound, per day seems to be like a good solid upper limit,
Yeah.
And maybe if you eat 1.2 to 1.4, you might get a tiny bit bigger, a bit, better, but it's going to be so small that no one's going to notice. Now, if you're an Olympic sprinter or something, then it literally, is between that 0.001 of a second, then go for it. Do that. But for most people, it's probably, not going to make that, big of a difference. And I think that's kind of, why you keep bringing up the law of diminishing return for all these things. Get it to a really, low level, but you don't necessarily have to biohack it to get it to a level where it's just completely abnormal or completely at zero if we're talking about LDL or say, something like that. Okay, just going on with the lipid markers here. So NMR particle size. So it seemed like a few years ago, people were really into like, hey, big fluffy is not so bad. Small dense is really terrible. And from my understanding now, it seems like even though the small particles may get through easier than the large particles, overall, there's going to be just as much particle through the large as the small, and essentially, it doesn't really make that much of a difference, is my understanding. So, like, is there any value to ordering like a particle size test, or is that sort of something that a lot of cardiologists don't really bother with these days?
I think I think
Or
most
maybe I'm
cardiologists.
wrong.
No,
Maybe there is
yeah.
some value to it.
Yeah,
Yeah.
no, most cardiologists don't. I think again, if you can use it to become more aggressive with somebody's somebody's either dietary modification, behavior modification, meaning if you can use it to make some change which we know to be beneficial, then fine. So again, you would be targeting not. I don't think it makes a lot of sense in the worried well. It does make sense in folks that say are high risk, like, and have diabetes, or say are demonstrating metabolic syndrome and insulin resistance, or have pre-existing heart disease. In those folks, again, using it once your LDL is 90, right? And again, the question is, who should we try to get to 40 or 50? Should we try to get everyone to 40 or 50? And I know pharma wants that because it's going to increase the amount of PCSK9 and bempedoic acid that's going
Yeah,
to
and
be
I want to
prescribed.
ask you about that a lot after, anyways.
Yeah.
But go ahead. Yeah.
So I mean, it's certainly that's the intent. Pharma would like everyone's LDL to be 40, because it's you're only going to get there with, for the
With
majority of the
pharma.
population, you're only going to get there with pharmacotherapy beyond a statin, which would be a boon for them. I just don't. I think we need to look at who's high risk. Just like, we should have, just like the vaccine rollout, right? I think you probably are going to do a lot better targeting the high risk. You're going to get into trouble if you are over aggressive with just doing it for everyone, because not everyone, there's cost, of course, to it. And again, there's adverse events to all of these different things that we use. There's an adverse effect profile to everything that we use to get you to beautiful numbers, right? And so again, I think there's a certain high risk group of folks that you can check, and if you do have lots and lots of small, dense particles, okay, let's try to be more aggressive with your getting your LDL down, or getting your triglycerides down, whichever way, whether it be statins or diet. But that's how I would consider using that.
Okay. Understood. So basically, if your LDL is, okay, but your, particle size is way, way, way off, then maybe you need an LDL that's a little bit subnormal. Maybe. And again, we're talking not about minutia here, but smaller diminishing returns, and say, dropping your LDL from 200 to 100, or 200 to 80, or whatever it is that would make a
Right,
dramatic
right.
difference.
And I think, again, it may make, that's why it may make more of a difference to those drops at that lower end may make more sense, because that benefit's going to be higher if your baseline risk is much higher, right? So if your baseline risk is much higher when you have all these things. If you're, an insulin dependent diabetic, if you have if you've had, like, 6 stents and you've got peripheral vascular disease, right? These are folks that are very high risk. And even when their LDL is 90, okay, the question is going to become, do you drive them down to 50? And I think one reasonable outcome, which obviates the need for advanced lipid testing, or ApoB, or lipoprotein A, is to say, hey, I mean, the clinical picture here tells a story. They've had all these events. They are very high risk. Let's drive them down to 40 or 50. I think so. In those cases, it may be a no-brainer just to be more aggressive. Now, in somebody that's a diabetic that has not had events yet, you could try to make the argument, like, well, before they have all these events, maybe you want to be checking, these additional risk factors. These additional blood tests, these advanced lipid testing, to drive them down further. So a diabetic with an LP little a that's normal, maybe you're okay leaving them in the LDL at 90. Whereas a super high LP(a) and a high CRP, and their small dense particles are like through the roof. Okay, this is the diabetic that I'm going to drive down to 30, 40. So.
Okay, one last marker, and I promise this is the last one. Do you use the oxidized LDL marker? And I sort of have a little bit of a hypothesis on this one too. So, from my understanding, we know that olive oil, has some associations anyway with, decreasing cardiovascular risk, all-cause mortality, but monounsaturated fats are not unique to olive oil in any way, shape, or form. I mean, monounsaturated fats are in tons of foods. And so they have a polyphenol in it called oleoperin. I think I'm saying that right. Maybe I'm not. Anyways, that's supposed to really inhibit the oxidation of LDL. And I'm thinking maybe that's part of the reason why, people who consume olive oil may have lower risks of cardiovascular disease. And of course, if they're substituting, monounsaturated fats for saturated fats, then, I think that's part of it too. But again, that's not unique to olive oil, but this polyphenol is. So my question is, do you use the oxidized LDL test, and would you use any kind of treatments to lower an oxidized LDL if you saw someone that had a high oxidized LDL?
Yeah, that's a great question. You're teaching me here. I have not actually. I've heard of an oxidized LDL. There was this Finnish study that showed people with high oxidized LDL, are more likely to develop metabolic syndrome. I have not. I have not used it, and I should just plead the fifth here. So I'm going to refer people to Dr. Hart if they come to me with high oxidized LDLs. What you're saying sounds reasonable, but I'd have to look into it a little bit more to sort out what to do about a high oxidized LDL. The only thing I know about it is that I recall some study that suggested a higher progression to metabolic syndrome. But do you know if so? Is there a study that shows that high oxidized LDL, these folks have a much higher cardiovascular event risk? I guess if they have metabolic syndrome, that would seem to make sense. But I don't know what exactly that number is and how much it raises it and stuff.
So the events that I saw, the studies that I saw, it seemed like these people had high LDLs also. Like, I'm not sure if there's a study that indicating that someone with high LDL but low oxidized LDL is okay. I've never really seen that teased out. So I think some of this is still, in the infancy stage, but something I think that I'm just going to kind of keep my eye on, I guess you could say, So I know I only have it for another, 5 or 10 minutes. So I'll be very, very selective with my questions here.
Sure.
So a big one that, I think a lot of people want to know, this is maybe one of the most common cardiovascular, questions that you maybe get is, 81 milligrams a day of aspirin. A lot of people, want to know whether they should take it or not. And, the way that I see it is that if there's a lot of heart disease in your family and you have no gut issues, it's probably, for you, then maybe the benefits do outweigh the risks. But, if you're a super healthy, person, you have no real cardiovascular risk factors, I don't know if adding the 81 milligrams a day of aspirin is really going to lower it further. So, what is sort of the general approach in the cardiology world with the 81 milligrams of aspirin?
Yeah, so there were these recent trials done in today's, in today's world where, where the prior studies, low amount of statins or not, maybe of course the initial ones, there were no statins around, it was just aspirin. And there, you saw this significant difference, whatever, you can argue about what significant is, but for primary prevention, a reasonable decrease in the rates of MI and stroke. And I guess now on a background of high doses of statin therapy, low LDL, revascularization, you're seeing a significant attenuation of the benefit of aspirin, which has, of course, led to, understandably, and I think it's smart to revisit whether or not everyone over the age of 45 who's male should be on a baby aspirin, and certainly that does not seem to be that seems not that seems like it's not something that should happen, because maybe statins are doing so much work, and the benefit of aspirin on top of that is relatively small. But I think even if you look at the recent trials that were done, there were lower MIs in the aspirin group. It's just that they were overcome by the higher rates of GI bleeding that were seen. Now, interestingly enough, I think it's important to recognize that cardiovascular disease, certainly from the ages of, in the younger years, right, 40s to 60, there's a lot of men that are having a lot of coronary disease. So cardiovascular disease certainly afflicts men in a very malignant way in a much earlier time period. And so I think you want to be careful about, and again, in those younger men, the rates of GI bleeding are not as high. So the GI bleeds in the studies, right, they're grouping men and women together. The GI bleeds are more happening in women. Of course, women also have a lower prevalence of coronary disease. Women catch up in terms of coronary disease much later in life. And so I think it's a little bit of a hodgepodge. So therefore, what you're saying is correct. I think if somebody is high risk, I think you are, and they're low risk, relatively low risk for GI bleeding. Yes, I think a baby aspirin does reduce their risk of an MI or stroke, and I would give it to them, right? And I would especially consider it in your male population, because again, I think there's a higher residual risk in that younger male population, right? And I think it's maybe a mistake to de-escalate in higher risk, especially men at a younger age. I think the real question is, is there a way to screen? And again, we'd have to do some type of trial, but this is the place where, you could try to use some mechanistic reasoning and hopefully not get into too much trouble to see, okay, if there's evidence. So, so maybe, this is a place where calcium scans or carotid ultrasounds or something may make sense in somebody that has a very high premature, very high risk, because maybe they're 40 and maybe they're a smoker, or maybe maybe they have a premature family history of coronary disease with, male relatives less than the age of 55 that are having heart attacks. Maybe that's a group that you want to take a look at a little closer, whether with a calcium scan or whatnot, to see if they have calcium there. Then, okay, this is somebody that should be on aspirin if they're not, and then of course, do you want to be aggressive with their statins and all that stuff as well? But I do think we're kind of throwing out the baby with the bathwater if we're allowing GI bleeds, which GI bleeds are terrible, whatnot, but you're talking about strokes and heart attacks, which is dead heart tissue, dead brain tissue, versus GI bleeding, which, yes, people die from GI bleeding, but, generally speaking, it's a reversible thing that we're able to manage in, first world settings at least. So yeah, no, I think we don't want to just de-escalate aspirin for everyone. I think there's a group of people, probably your average 50-year-old woman who used to be just put on aspirin that their risk is relatively lower, right? I don't think, and then that GI bleeding risk now starts to predominate. So yeah, I think that's where, looking at the RCT, we should kind of try to understand what was happening here, and how this is a place where having half the population be women, or sorry, a large proportion of the trial population being women. It's not that we shouldn't have that. It's just that then you need to understand how that throws off the conclusion a little bit, right? If you ran the same trial with 90% men, then maybe you'd have a different outcome, because that event rate reduction would be much lower. So you drop the events, the cardiovascular event rates much lower. I hope that makes sense.
No, it makes total sense. It's hard to put a blanket statement on who or who should not be on aspirin, but essentially, like, if your cardiovascular risk is higher than your, GI bleed, and you're in a male above you're a male above your 40s. I mean, it seems like the risk benefit ratio is in favor of aspirin. And, I certainly, have told some of my patients who fall in that category to take it. And, I'm going to continue to do that. So I know our hour is coming up here. There's so much more that I want to chat with you about. So I do want to have you back on at some point.
Yeah, no worries.
Because this has been awesome. You've answered so many of my questions here today. But before I let you go, can you just tell people where they can find you online? Tell them about your Substack, about your Twitter handle, and maybe a little bit about about where you practice and where people can contact you.
Yeah, so you can find me on Twitter at Anish_Koka. I have a link to the Substack there, and it's also anishkokamd.substack.com. And I have a practice in Philadelphia, and and I have the website is phillyheartdoc.com, because I'm the only Philly heart doc. I'm kidding. I'm one of one of thousands. I think just in the block where my practice is, every time you trip over a cardiologist as you walk down the block. So lots and lots of cardiologists in Philadelphia. Those cheesesteaks, they certainly promote disease. So I have the suspicion that the cardiologists are giving their Philly patients, donuts and cheesesteaks. That's why there's so much disease. We're not like those
That
dentists who are
eliminating
disease by handing out toothbrushes and fluoride and whatnot.
And I think you tell your fans to get super angry at games, right, and that probably triggers heart attacks too.
Yeah, right? There's a lot of cortisol and stress, man. Those games, the Phillies fans, they are no joke. They will, it's so funny, man. If you could be like the number one team, and then we could have the number one team, but man, lose a few games in a row, and that's it. Coach needs to get changed. The quarterback needs to go.
Yeah,
they're tough. So
it's not really the city of brotherly love then. Anyways, great to have you on, brother. Really great to chat with you. And absolutely. Like I said, I do want to have you back on. And thanks so much, everyone, for listening. I really do appreciate that. And I'll be back again with another episode soon.
Yeah, I was going to say there's every Monday, we're actually trying an invitation to you and others who want to listen. Every Monday, around 8 p.m. Monday or Tuesday, 8 p.m. Eastern Standard Time, we're trying to do a Twitter Spaces where we're talking healthcare policy. And you practice in Canada, and it's always interesting as the American docs who are very like insular, and the world revolves around the U.S., which isn't the case. And it's one of these things where it'd be super interesting to get other perspectives. So please, I hope you join us on some of these health policy discussions so we can get kind of the Canadian perspective. So
yeah, and sorry, what just the times again there?
It's 8 p.m. Eastern Standard Time. Usually it's on Monday or Tuesday. So I think this next one coming up, because Monday's Labor Day, it's going to be Tuesday at 8 p.m. So yeah, that last.
Well, I'll try to make it.
Yeah, the last week we discussed physicians and unions and the upsides and downsides of forming unions, and so and the next one is going to be talking about scope creep. The physician assistants and the nurse practitioners versus the doctors, and what are the implications of all of that. So.
Cool, man. Well, that sounds dope. So, I mean, we could do a podcast just on that. But I know. Yeah, I'll definitely be at one of those meetings though soon. So appreciate the invite. Cool, brother. Well, let's end it here. And again, thanks so much everyone for listening. I appreciate it.
Alrighty, take care.